All right, if you're a medical trainee, you are going to see a lot of COPD, or chronic obstructive pulmonary disease. So today, we're going to do a really practical run-through of how you can confidently diagnose and stage one of the most common respiratory diseases you will ever encounter. Let's dive right in.
So, why all the focus on COPD? Well, check this out. Before the COVID-19 pandemic hit, this was the third leading cause of death worldwide. We're talking about a disease with a massive global impact and a huge burden on patients and healthcare. So, getting this diagnosis right, it really matters.
So what exactly are we diagnosing here? Well, the official GOLD definition is a mouthful, but the words to zero in on are persistent and progressive. That means the airflow problem, it doesn't just go away, and it usually gets worse over time. And that other word, heterogeneous, that just means it can look really different from one patient to the next. Okay, let's clear up the biggest point of confusion right out of the gate. COPD versus asthma. What is the difference? It all comes down to one word: reversibility. With asthma, that airflow limitation is often reversible, right? It can get better on its own or with treatment, but with COPD, as you see here, it's persistent. That is the fundamental physiologic difference we are looking for.
All right, so here's our game plan for this explainer. We're just going to walk through it like a real clinical encounter. First, what is this thing? Then, how does the patient present? How do we confirm it? What else could it be? And finally, how bad is it?
So, let's start with that foundation. What is COPD? We know it's a disease of persistent, progressive airflow obstruction, and we know it's not the same as asthma. So with that in our back pocket, let's look at how these patients actually show up in the clinic.
And now for the fun part, the detective work. This is all about the clinical presentation. What are those key clues in a patient's story that should make a little light bulb go off in your head and make you think, could this be COPD?
These are the big ones to listen for. The classic triad is shortness of breath, a chronic cough, and bringing up sputum. But here's a clinical pearl for you. The most common early symptom is often that shortness of breath with activity. And you might have to dig for it. Your patient might not say, "I'm short of breath." They might just say, "Well, I don't really go bowling anymore."
Next up, while you're taking that history, you've got to ask about risk factors. And look, while tobacco smoking is #1 with a bullet, it is not the only cause. For sure, you need to calculate pack years, but you also need to ask about jobs, about fumes, about what they cook with, and even about family history that might point to a genetic link.
Now, on your physical exam, what you find really depends on how severe the disease is. And here's the thing. In mild COPD, the exam can be totally 100% normal. As things get worse, you might hear decreased breath sounds or wheezes. Oh, and pay close attention to that last point, digital clubbing. That is a huge red flag. It is not a feature of COPD, so if you see it, you need to start looking for something else.
Okay, so you've taken a fantastic history, you did a thorough exam, and you're thinking, this really sounds like COPD. So how do you prove it? Well, that brings us to spirometry. This is the single most important, essential tool for locking in the diagnosis.
And the good news is, the process is really straightforward. It all starts with your clinical suspicion. Then, you do the test to measure FEV1 and FEC. After that, you give a puff of a bronchodilator, you wait a few minutes, and you do it again. The final step? You just calculate the ratio. That's it.
And this is the magic number. This is what it all boils down to. A post-bronchodilator FEV1 to FVC ratio of less than 0.7. That number confirms persistent airflow limitation. This is the objective data that nails the diagnosis for you. So let's make this real. Imagine this report pops up in your EMR for that patient you've been seeing. You look at the result. Post-bronchodilator FEV1/FVC ratio is 0.65. So what does that tell you? It tells you got it. Diagnosis confirmed. That number is below the 0.7 cutoff. Your clinical suspicion was right on the money, and now you have the hard data to back it up. This patient has COPD. But wait, we're not done yet. Just because we've confirmed the diagnosis, that doesn't mean we can stop thinking. A great clinician always asks, okay, what else could be going on? So let's talk about the differential diagnosis. This is such a high-yield slide. Lots of things can look like COPD or even happen at the same time. For heart failure, for example, you want to listen for those crackles at the lung bases and maybe get a chest x-ray. For bronchiectasis, the big clue is that daily, nasty, purulent sputum. And for asthma, well, we already talked about it. It's all about that significant reversibility on their spirometry. So, We've confirmed the diagnosis, and we've ruled out the major mimics. The next big question you have to answer is, so what? How bad is it? And this brings us to our last step, staging and assessing severity. This is absolutely critical for figuring out how to treat the patient.
So the traditional way we've always graded the severity of the airflow problem is with these gold grades you see here. This is based purely on one number, that post-bronchodilator FEV1 as a percent of what we'd predict for that person. It just gives you a simple snapshot of their lung function from mild all the way to very severe.
But here's the question that really changed how we think about this disease. Does that one number from the breathing test, does it really tell the whole story? Does it tell us how that person feels walking to the mailbox? Or what their risk is of ending up in the hospital next month?
And the answer is no, not really. And that's where this modern approach comes in. The GOLD-AB tool helps us group patients for treatment based on the two things that actually matter most to them: how bad their symptoms are day to day, and what their history of flare-ups or exacerbations looks like. This is what really guides our treatment choices.
So if you remember nothing else from this section, remember this little phrase: grade with FEV1, treat with ABE. It's so simple. You use the FEV1 to grade how bad the lung physiology is, but you use the ABE assessment of their symptoms and their risk to actually decide on the treatment. It's just a much more patient-centered way to think.
And there you have it, the whole journey, from that first clinical suspicion to the objective proof, and finally to a thoughtful assessment of severity. But the story isn't over, and the question I want to leave you with is, what's next? Are we going to start diagnosing pre-COPD before the damage is done? How will things like advanced CT scans change how we manage this? That's the exciting, evolving landscape that you all will be shaping.